Good evening, ladies and gentlemen. I would like to welcome you in the session of challenging cases of acute coronary syndrome and complications. My name is Dr. Musa Akbar. I will be have the pleasure and honor to moderate the session with our colleagues, panelists, Dr. Abdulaziz Al-Githami from the National Guard Hospital in Saudi Arabia. I would like to welcome him, as well as Dr. Ahmed Majdi from National Heart Institute in Baba in Egypt. Welcome, Dr. Ahmed Majdi, as a colleague and panelist in my session today. And also I have three speakers, Dr. Ahmed Kassem from Saudi Arabia, would like to welcome you, and Dr. Samih Lawand, also from Saudi Arabia, and the last, Dr. Nouf Al-Anizi, also from Saudi Arabia. So we'll start with the first presenter and the first case, Dr. Ahmed Kassem, as he will present the challenge of a primary PCI in a STEMI patient with a huge thrombus burden. So Dr. Ahmed Kassem, I will leave the microphone for you to present your case.
GIS committee. It's my pleasure to share my presentation in this meeting, GIS, the challenge of a huge thrombus burden in STEMI. Our patient is 48 years old, female patient with no history of diabetes or hypertension, but she is heavy cigarette smoker, and she presented with severe typical chest pain of 8-hour duration. Upon arrival to emergency department, she developed cardiac arrest with ventricular fibrillation. CPR done for 5 minutes with 2 DC shock given, and successfully she revived. After that, ECG done and showed ST segment elevation, the anteroseptal leads. Patient underwent intubation and mechanical ventilation due to damping of level of consciousness, and taken after that to the cath lab for primary PCI. Coronary angiography done for her, normal right coronary artery, but this is the left coronary angiography showing a huge thrombus burden in the ostium of LAD with damping of the flow, TME0 flow in the mid segment of LAD, what we call AVDE, or angiographic visible distal embolization. And of course, actually, this is due to raised intrinsic fibrinolytic activity with fragmentation of this thrombus and distal embolization. And this instability of the thrombus causing distal embolization with mechanical plugging of small arterioles and even big arteries, like our patient with macro embolization of the LAD itself from the mid segment, like our case. So in this difficult scenario with a huge thrombus burden and the TME0 flow in the mid segment of LAD, what is the best strategy? Of course, according to the guidelines, European guidelines and American guidelines, the aspiration is a class 3 recommendation as a routine, but it is actually very mandatory in selected cases like our patient. So I decide to go for aspiration of this thrombus, and this after 5 times of aspiration showing a huge thrombus burden with red thrombus type actually. Of course, all of us know that red thrombus is fibrin rich, while the white thrombus is platelet rich. And of course, the red thrombus is commonly occlusive thrombus presented with STEMI. And we can easily discriminate the red thrombus by high backscatters and high attenuation in the ECT, OCT imaging of such a group of patients. And according to the Kedros et al. And his colleagues, there is a significant correlation between the red thrombus and the incidence of major adverse cardiac events, death rate, MI, and revascularization rate, and CVA. In comparison to white thrombus, of course, it is higher with red thrombus type. After aspiration failure, actually, there is no improvement in this flow, so I decide to give intracoronary medication, and this medication showing a slight improvement, but still TME0 flow distally. So after this aspiration failure, what is the next step? At that moment, actually, I decided to go for low-dose intracoronary thrombolysis selective injection distally in LAD, based on the data published by the European Heart Journal and Acute Cardiovascular Care, that showing that low-dose intracoronary thrombolysis is effective in reducing the thrombus burden and improving epicardial flow, and also improving the myocardial reperfusion. And they use in this study 1/3 of the systemic dose. Tenecteplase used in 27% and alteplase used in 73% safely, with successful rate in TIMI2 flow and more in 97% of patients in this study. So I decided to give tenecteplase 3,000 units, 1/3 of systemic dose, and there is improvement of the flow distally in the LAD. And I give again intracoronary vasodilators, and also showing significant improvement after that. So I feel this is the moment. But the question, OCT have a role in acute coronary syndrome? I think it is have significant role to assess thrombus burden, thrombus type, and to assess the ostial LAD, assess also the distal left mean as well. And this is very important data from the European Neurointervention Journal was using OCT in more than 100 patients. 94% STEMI underwent OCT in day 2 and day 3 to 6 and day 7 to 30. And actually, it is very important data showing that the result based on OCT, only 62% of patients underwent stenting due to residual lesion or plaque rupture or plaque prolapse, and another 37% of patients are deferred stenting and managed medically due to only erosion or healthy endothelium with just only a thrombus burden that dissolved after that. So this OCT is feasible in acute coronary syndrome and improve assessment of thrombus burden and decrease the percentage of stent use according to the conclusion of this study. And this is another important data also showing the role of OCT in prediction of the neuroflow phenomena by what we call it the lipid index. And of course, it is according to the lipid arc in addition to the lipid length, showing significant correlation with the incidence of distal embolization after stenting of this high plaque burden and lipid-rich plaque with lipid arc more than 200. So I decided to go for OCT to my patient showing a very large plaque burden in the ostial part of LAD with high lipid content in the plaque itself, and also it's showing there is a high plaque burden in addition to the lipid-rich plaque in the longitudinal view of this OCT image, and also showing there is a layered black pattern or layered black phenotype with some macrophage infiltration due to recurrent subclinical healing of ruptured plaque that can occur subclinically. And also this is a marker of actually vulnerable plaque with rupture of this plaque here clear. We can see this ruptured plaque, especially as the distal shoulder of the plaque with redus thrombus in the distal part of this, and this redus thrombus fills the lumen of the artery according to this OCT. And it is clear here that redus thrombus is settled beside the distal shoulder of the large plaque burden. And this redus thrombus actually it is clearly demarcated by the OCT, which can easily discriminated either in the longitudinal view or the 3D reformat. And of course, this images after we make aspiration and showing this residual, large residual thrombus. So it is very important that with the presence of this large residual thrombus after we make 5 times aspiration, and still the STEMI flow 1 or 2 and borderline pressure, it is very important actually to defer stenting in these cases. And we put the patient into Rofban infusion 48 hours, 0.15 mic per kg per minute. And this based on the defer STEMI trial, which is one of the largest trial. The guidelines relied on a recommendation of deferring, but it is not routine recommendation. It is only in selected cases, and they recommend that different stent strategy allows time for reduction in the thrombus burden and recovery of microvascular function. But the patient shifted to the CCU, and the second day, surprisingly, patient become very conscious, hemodynamically stable, pressure become okay, chest clear, the balloon stopped, and we wean from mechanical ventilation and extubated actually. And this is very important data from OCT study showing that the burden of residual thrombus is significantly correlated to the outcomes. It associated with worse microvascular dysfunction in addition to greater myocardial damage actually due to this huge residual thrombus burden. We did echo after that for the patient and showed akinesia of the apical segments with LV dysfunction grade 2 and trivial MR. And after 48 hours after tirofiban, patient showing angiography showing a clear dissolution of the thrombus from ostial part of the LAD and TIMI3 flow actually. And at that moment, we decide to make stenting. But based on the anatomy and based on the OCT images of distal left mean and ostial LAD and ostial circumflex, which is actually not too much affected, we decide to go for precise ostial deployment of the stent, Zions 35 by 18, then NSC alone 35 by 15 at 18 atmospheric pressure. And this is the final result after that with TIMI3 flow. And we this in comparison to the baseline angiography with TIMI0 flow, it is excellent results after we make different stent strategy and deployment of stent after 48 hours. Echocardiography, I decided actually to repeat again before sending the patient home because anterior STEMI is most commonly associated with LV thrombus, and this is actually what we find in echocardiography, large LV apical thrombus, which appear clear here in two orthogonal views, apical four-chamber view and the long axis view as well. So we started warfarin and the Plavix and patient follow-up in the outpatient clinic after that. But after 12 months, the patient presented again to us with chest pain. Because this is previous history, we decided to go for coronary angiography. And surprisingly, coronary angiography showing marvelous results and TIMI3 flow with recovery of the microvasculature completely, and ECG normalized, no T-wave inversion, no ST depression, no residual effect from the previous attack of acute coronary syndrome. And not only that, but also the baseline echo, which showed severe akinesia of the apical segment of the LV, showing also significant improvement of the function of the LV with near normal revive of the ejection fraction to nearly normal. And this another four-chamber view showing also the significant improvement of the apical akinesia in this case, which is actually very marvelous results after complete revascularization of the LAD and give time for recovery of the microvasculature in this case. So my take-home message, STEMI with large thrombus is still a real challenge. Reddish thrombus is usually associated with a huge thrombus burden and high incidence of AVDE. Massive distal embolization is probably a major part of underlying mechanism of neuroflow phenomena. Electrical instability and STEMI may be a marker of massive ongoing ischemia due to distal embolization, and OCT imaging is a gold standard to detect the ACS mechanism, either a plaque rupture like our patient, erosion, calcium nodule, etc., or low dose intracoronary thrombolysis is safe and effective therapeutic strategy, especially after failure of STEMI aspiration with a huge thrombus burden and massive distal embolization, and different stent strategy in STEMI with massive thrombus burden and AVDE is better than stenting, especially with the evidence of large residual thrombus by imaging to avoid the potential risk of early in-stent thrombosis and worsening of myocardial tissue perfusion, and aggressive intracoronary vasodilator followed by intravenous infusion of 2B3 inhibitors, a successful strategy to improve TIMI flow in cases with massive distal embolized thrombus. Thank you very much.
Thank you very much, Dr. Ahmed Kassem. Very nice case, illustrated, presented, and very nice and well-managed case. You know, before I will address the question to my colleague as a panelist, there are challenges of large thrombus burden. One of the challenges is the re-occlusion. The TEMI flow remains 0 or 1. You cannot visualize the distal. You underestimate the vessel's diameter and the distal embolization, and also no reflow after ballooning or stenting. This is another challenge. And the last of the challenge is that the embolization to non-couplet vessels. Luckily, in your case, is an ostial very close to LAD, to the left main and circ, and there was luckily not just embolized to the non-couplet vessels. So if I ask Dr. Ahmed Majdi, what do you think we should do in a large burden thrombus? Do we have really a guideline or algorithm to which, when we use the pharmacological approach, mechanical approach, should we use intracoronary thrombolytic as a low dose, as Dr. Ahmed Kassem presented in his case? Dr. Ahmed Majdi?
I thank you for inviting me to the GIS and the acute syndrome sessions and intervention. We need to go by the book, and we need to go step by step. We cannot judge that this artery is totally occluded by a thrombus or any kind of intervention, except many cases after we pass a wire. Sometimes when you pass a wire and it is a critically obstructed artery, sometimes this flow itself may improve. And you cannot leave a patient with total occlusion because there is a heavy thrombus, because he will develop a huge infarction. So in many cases, maybe he was lucky that this case, the obstruction is maybe 60%, 70%, that's severe. If it is a critical obstruction, you have to improve the hydraulics. You have to open the artery. You have to pass a wire. Sometimes the total occlusion transfers into maybe it was a 95%, and the passing a wire will disturb. Maybe it's partly thrombus like this one, and so passing a wire will make the story different. The third PCI, as with my colleagues and with you, it's 2014 and then again 2017. It is after the deferred self-study. So it is not, except in very few cases. I think this case, yeah, you have the lesion was not that severe. That's why you had the option of leaving the patient. I would do this case next morning. I cannot wait for 48 hours because re-occlusion here is almost 50% or maybe 70%.
Thank you. Dr. Abdulaziz, would you want to comment on the case? You would like to add anything additional to what we have said? Dr. Abdulaziz.
Unmuted.
Unmuted, Dr. Abdulaziz. Tfadal.
Thank you for the organizing committee to invite me. It's a great case, Dr. Kassem. Actually, it's a pleasure to see this. All tricks actually had been done in this case. As Dr. Majdi mentioned, there is many steps that you follow to prevent non-reflow in this case. And there is a conflict in data actually in regard of intracoronary thrombolysis, including JAMA article for randomized trial for intracoronary improvement of no reflow in 2019, and that showed actually no improvement. But in your case, actually, it's a different setup because you tried everything and actually didn't had been much improvement. You did OCT and there is still a high thrombus burden, and you elected to go for thrombolysis, which is, I think it's a different than what had been studied in that population. And at the same time, we did actually a couple of cases where we had actually large thrombus burden in our center, and they actually do okay if they had been on anticode in tyrofeban or integralin for 24 hours, and we do the next day, and actually their TEMI flow usually actually improved significantly. And we do that usually for patients who have a high thrombus burden, and we do think that this is had been almost not only in our experience, we saw it in other centers in Riyadh, that actually when you do have a younger population, when they have a high burden of a thrombus, and you do cut them, you do balloon them, you do aspirate, and there is no much of actually improvement of the flow. The tyrofeban actually do very well, or abciximab if you have a renal dysfunction, as you know. But it's a great case, and salute you for that.
Thank you very much, Dr. Abdulaziz. If I will ask one last 1 minute for you, Dr. Ahmed Kassem, you know, everybody doing aspiration catheter and glycoprotein. So what is your message in this case? When should you use a low dose of intracoronary thrombolysis? In which cases of a huge, what are the criteria that make you comfortable to use it if your mechanical measures and pharmacological measures have failed?
Dr. Musa, I have a comment whenever you have a chance, please. Dr. Badr Zahrani.
يا اهلا وسهلا. انا ما شفتك. يا اهلا وسهلا. Please, I will give you. بس احمد قاسم خليه يجاوب and I will give you a comment.
Okay, thank you. Yeah, of course, this is one of the most important line of treatment of huge thrombus burden. We have very different lines, including laser therapy, including rheolytic therapy, and of course, because huge thrombus burden should be individualized. There is no clear guidelines for a huge thrombus burden, which line is better than the other to handle this huge thrombus burden. And the most important issue in huge thrombus burden, trying to protect the microvasculature. And microvasculature is our target to save the myocardium, not just only the myocardial artery, because in our case, the major factor determining the outcome in our case is the distal embolization. This patient had spontaneous distal embolization and the blockage of the microvasculature and even the macrovessel distal part of LAD. So my target is to dissolve this, try to dissolve this thrombus that already blocked the microvasculature. And of course, if we leave it like this, it will be affected the outcome. It will be a very poor outcome in terms of remodeling. But which criteria you ask about is which criteria we should apply low dose thrombolytic therapy. My opinion, I think it is a huge thrombus burden which is not resolved by any other, and most importantly, if it is radius thrombus, like I mentioned today, because it is rich in fibrin, and also if it is not too much time passed, not late presentation, STEMI, for example, because early thrombus can easily respond to thrombolytic therapy if it is given in situ, local.
Thank you very much, Dr. Ahmed. And I would like to welcome Dr. Badr Zahrani from Military Hospital, Riyadh. I don't see your picture, but please add a comment if you want, Dr. Badr.
My pleasure. Thank you for the invitation. Just a couple of comments about aspiration thrombectomy in general. The total trial published in 2016, it was really a well-randomized trial, about 10,000 patients. They randomized them to routine aspiration thrombectomy followed by PCI versus conventional PCI. And if you look at the MACE events, it's about 10,000 patients. There was no MACE difference in terms of primary outcomes and the aspiration thrombectomy versus the conventional PCI arm. That's number one. Number two, in fact, we have to be careful about the aspiration thrombectomy for the reason that the stroke risk is higher. So if you look up the guidelines, they say it's a class 2B, I think, to do a routine and high thrombus burden. It made class 3 actually to do a routine aspiration thrombectomy unless there is high thrombus burden. But if you look up the follow-up on those patients, there was actually no difference in primary outcomes even after 3 years of the randomization of the trial. So the stroke risk when you do aspiration thrombectomy is about 0.7% versus 0.3% if you just do a conventional PCI. But I understand there are some tough cases that despite the ballooning and all that, you still have no reflow and there is high thrombus burden. What should you do with those cases? And this is kind of a good discussion to talk about.